Before birth, a fetus does not use its lungs to breathe. Because they are filled with fluid, the lungs present a high-resistance environment. To survive, the fetal heart relies on a temporary vessel called the ductus arteriosus to bypass the pulmonary circuit entirely, routing oxygenated blood straight into the systemic circulation. Normally, this vessel closes shortly after a newborn takes its first breath. When it remains open into adulthood, it becomes a patent ductus arteriosus, or PDA. Structurally, it is a persistent connection between the descending aorta and the left pulmonary artery, located just distal to the left subclavian artery. Pediatric cases are often linked to complex congenital defects or historical causes like in utero maternal rubella exposure. In modern adult congenital cardiology, however, a PDA typically presents as an isolated lesion. This chart compares typical adult aortic pressure with pulmonary artery pressure. Once the lungs inflate at birth, pulmonary vascular resistance drops drastically. Meanwhile, systemic vascular resistance rises. This establishes a permanent, steep pressure gradient from the high-pressure aorta to the low-pressure pulmonary artery. Because the aorta sits at a consistently higher pressure than the pulmonary circuit, an open ductus acts as a relentless escape valve. The blood continuously shunts from left to right, flowing out of the high-pressure aorta and flooding the pulmonary artery. A PDA operates as a dynamic, chronic pressure leak. It continuously siphons off systemic volume and forces the cardiopulmonary system to work harder simply to maintain baseline perfusion. The physical diameter of this anatomical leak directly dictates the patient's bedside presentation. A small ductus might be entirely silent, but a larger defect produces a highly specific clinical signature on physical exam. The defining acoustic feature is a rough, mechanical sound, frequently described as a machinery murmur. This is the audible turbulence of high-velocity blood being forced continuously through the narrow ductal channel. This Wiggers diagram charts the pressure curves of the cardiac cycle. Aortic pressure remains higher than pulmonary pressure at all times. Because the gradient never equalizes, the turbulent flow and the resulting machinery murmur are continuous through both systole and diastole. Due to the anatomical location of the ductus, clinicians traditionally auscultate this continuous murmur best just inferior to the left clavicle. This constant runoff into the pulmonary bed has another mechanical consequence. It abnormally lowers the diastolic pressure in the aorta, significantly widening the overall pulse pressure. This widened pulse pressure is readily apparent in the extremities. Upon palpation, patients often exhibit unusually brisk or bounding peripheral pulses. The classic physical exam findings of a PDA are the direct acoustic and tactile manifestations of systemic blood volume being steadily stolen by the pulmonary circuit. All of that excess blood shunted into the pulmonary circulation must complete the circuit. It travels through the lungs and returns directly to the left atrium and left ventricle. This forces the left heart to pump its normal cardiac output plus the extra shunted volume. Over time, this chronic return initiates a cascade of progressive volume overload, driving left ventricular dilation. Standard two-dimensional transthoracic or transesophageal echocardiography is the first-line diagnostic tool. Clinicians utilize the suprasternal notch and high parasternal short-axis views to capture the continuous color Doppler flow of the ductus. The 2025 AHA/ACC guidelines issue a Class 1 recommendation that all adults with a PDA must undergo an explicit assessment of left ventricular function and left-sided chamber size using echocardiography, cardiac MRI, or both. This volumetric model compares a normal pulmonary to systemic flow ratio, or QP to QS, of 1:1 against a hemodynamically significant left-to-right shunt of 1.5:1 or greater. Cardiac MRI provides superior quantification of this exact ratio and is highly sensitive in detecting early left ventricular remodeling before symptoms appear. Cardiac CT, meanwhile, is generally reserved for precise anatomical mapping of the ductus and aortic arch immediately prior to transcatheter closure interventions. Advanced imaging strictly quantifies the destructive impact of the shunt on left ventricular architecture, providing the objective data needed to justify intervention. While the left ventricle handles the volume, the pulmonary vasculature absorbs the pressure. Chronic pulmonary overcirculation exposes the fragile lung vessels to severe shear stress, triggering dangerous endothelial changes. Continuous high-pressure exposure causes the walls of the pulmonary arterioles to undergo physical remodeling. They thicken, stiffen, and narrow, progressively restricting blood flow and driving pulmonary arterial hypertension. In the context of a PDA, the clinical threshold for pulmonary arterial hypertension is strict, a pulmonary vascular resistance, or PVR, of 2 Wood units or greater. The 2025 AHA-ACC guidelines establish an additional Class 1 recommendation. Every patient with an unrepaired PDA must be explicitly evaluated for PAH to guide treatment decisions. If non-invasive testing cannot definitively rule out PAH, clinicians are mandated to perform an invasive hemodynamic assessment via cardiac catheterization. Left heart dilation reflects the mechanical burden of the PDA, but the irreversible destruction of the pulmonary vasculature represents the most significant threat to patient survival. This flowchart from the 2025 AHA-ACC guidelines provides the definitive roadmap for PDA risk stratification and intervention. It begins directly with the mandate to evaluate any hemodynamically significant shunt for PAH. For patients with left heart enlargement and a net left-to-right shunt, the path is straightforward. If there is no evidence of PAH, meaning a PVR of 2 Wood units or less, PDA closure is a Class 1 recommendation. When PAH is present, the guidelines stratify patients into an intermediate zone. A temporary balloon test occlusion of the PDA is a Class 2A recommendation to accurately quantify the PVR and observe how the pulmonary circuit reacts when the shunt is blocked. If test occlusion confirms the PVR sits strictly between 2 and 5 Wood units, proceeding with PDA closure remains a reasonable Class 2A option. For higher-risk patients presenting with a PVR of 5 to 8 Wood units, the guidelines dictate a treat and repair strategy, requiring direct consultation with pulmonary hypertension specialists. In this 5 to 8 Wood unit cohort, targeted PAH medical therapy must be initiated first. If post-treatment PVR drops below 5 Wood units, closure may be considered as a Class 2B recommendation, but PAH medical therapy must continue indefinitely. The 2025 guidelines establish a highly stratified intervention pathway, dictated entirely by these precise PVR calculations. Looking at the far right of the algorithm, we find the most critical restriction. When pulmonary vascular resistance exceeds 10 Wood units, the patient has reached Eisenmenger physiology, and closure is absolutely contraindicated. In Eisenmenger syndrome, the pulmonary vascular resistance has climbed so high that it surpasses systemic aortic pressure. The pressure gradient flips, and the shunt entirely reverses its direction, flowing from right to left. This schematic illustrates how the anatomical location of the PDA creates a unique clinical phenomenon. Oxygenated blood exits the brachiocephalic and subclavian arteries, while the reversed, deoxygenated blood from the PDA enters the descending aorta, entirely downstream of the upper body circulation. This structural arrangement results in differential cyanosis. Because the deoxygenated right-to-left shunt enters the descending aorta, the patient's head and arms remain pink, while their lower body, legs and toes become severely cyanotic and clubbed. Because of this downstream mixing, pulse oximetry must be explicitly checked in both the hands and the feet of all patients to detect occult right-to-left shunting. The 2025 AHA-ACC guidelines issue a strict Class 3 warning against closure in this state. In Eisenmenger physiology, the PDA acts as a vital pop-off valve for the failing right ventricle. Closing it precipitates acute, fatal right heart failure. Pregnancy is likewise strictly forbidden. The structural defect that initially triggered the patient's cardiopulmonary failure eventually becomes the only hemodynamic relief valve keeping them alive.